This explainer is based on postural orthostatic tachycardia syndrome, POTS, a vestibular physician's deep review of diagnosis, pathophysiology, and management, published by Australian Dizziness Clinics.
Welcome back to part 3 of our explainer series. Today, we're diving straight into the clinical face of POTS. While POTS is a deeply complex, multi-system condition, it so often presents right in front of us as a vestibular issue. Our goal today is to learn exactly how to spot it.
Picture this clinical vignette. Worse standing, better lying, worse after meals, heat, and deconditioning. We're talking about a young woman with years of unexplained dizziness and totally normal scans. Now, this isn't just a random assortment of vague complaints. This pattern, this specific overlap of symptoms, is the diagnosis itself. And yet, patients often endure a massive diagnostic delay of 5 to 7 years just because these clues get missed. The pattern really is the key. To break this all down, we're going to follow a highly organized, systems-based approach today. 1. The classic portrait. 2. Core orthostatic symptoms. 3. Systemic features. 4. Vestibular overlap. 5. Diagnostic red flags. And finally, 6. Key takeaways. All right, let's jump right into section 1. The classic portrait. More than just a rapid pulse.
So, POTS is fundamentally a systemic syndrome, but it frequently masquerades as pure dizziness right in our vestibular clinics. A typical patient is going to experience a real escalation of cardinal symptoms. We're talking palpitations, presyncope, and this intense lightheadedness and cognitive dysfunction that patients colloquially call brain fog. But here's the absolutely crucial point, the positional trigger. These symptoms consistently get worse when they're upright, and they ease up almost right away upon sitting or lying down. Plus, you'll see them noticeably aggravated by external stressors, things like heat, heavy meals, or periods of physical deconditioning.
Moving on to section 2, core orthostatic symptoms, the gravitational challenge. Let's look at the actual mechanics of why these orthostatic symptoms happen. You see, when a patient stands up, gravity naturally causes blood to pool in the lower body. Normally, our bodies compensate just fine, but in POTS, this blood pooling reduces the venous return to the heart, so reduced preload. With less blood coming back, the heart kind of goes into overdrive, kicking into a compensatory tachycardia to try and maintain output. But even with that rapid heart rate, there's often transient cerebral hypoperfusion. Simply put, the brain just isn't getting quite enough blood flow, and that directly drives the lightheadedness and that infamous brain fog. Now, check out this statistic because it might actually surprise you. Less than 30%. While presyncope, that dreadful feeling that you're just about to pass out, is incredibly common, frank syncope, or actually losing consciousness, happens in fewer than 30% of POTS patients. So it's really the relentless daily orthostatic intolerance that defines this condition, not necessarily the act of fainting. Okay, section 3, systemic features, a multi-system presentation. The core orthostatic symptoms we just covered, well, they definitely don't exist in isolation. POTS brings along an incredibly wide, complex array of systemic features. To prevent cognitive overload, let's chunk these into some manageable domains. Cardiovascularly speaking, beyond just palpitations, patients often get chest discomfort and acrocyanosis, that purplish pooling of blood in the lower legs when they stand. Neurologically, it goes way beyond brain fog to include headaches and visual blurring. Then there's the gastrointestinal system, heavily impacted by autonomic dysmotility, leading to lots of nausea and bloating. Thermoregulatory issues are huge too. Extreme heat intolerance, upper body sweating, and uniquely in neuropathic POTS, a complete lack of sweating in the feet, which is known as foot anhidrosis. And crucially, across all of these domains, secondary anxiety is incredibly common due to how unpredictable these symptoms are. But remember, anxiety must never become the primary diagnostic label.
Next up, section 4, vestibular overlap, hypermobility and mast cells.
Now, there are 2 major overlapping conditions you absolutely have to keep on your radar because they significantly impact how the vestibular patient presents in your clinic. First up is hypermobile Ehlers-Danlos syndrome, or HEDS. This is present in a staggering 40 to 70% of POTS cohorts. That connective tissue laxity impairs venous integrity, basically making the blood vessels way too stretchy, which severely augments that blood pooling we talked about earlier. Equally important is mast cell activation syndrome, or MCS, seen in about 10 to 20% of patients. Here, mast cell mediators amplify autonomic instability, driving some intense episodes of flushing, GI distress, and tachycardia.
And here's a massive clinical pearl for you. Vestibular migraine co-occurs with POTS at a much higher than chance frequency. So,
What does this mean for us? It means that dizziness in these patients is very often multifactorial. I mean, you could completely stabilize their orthostatic heart rate, but if they've got an active vestibular migraine, they are still going to feel dizzy. This really urges us to screen for migrainous features in every single POTS patient who presents with vertigo or dizziness.
All right, Section 5, Diagnostic Red Flags, Defining the Boundaries. To confidently define what POTS is, we really have to define what it isn't. Let's juxtapose POTS against classic orthostatic hypotension, or OH. This is a critical boundary. In classic OH, the primary issue is a true sustained fall in blood pressure upon standing. But in POTS, the blood pressure generally remains stable. It's the heart rate that spikes to compensate. So by definition, these two conditions are mutually exclusive during a single test. Mapping out these red flags is going to prevent some serious misdiagnoses. For orthostatic hypotension, your key feature is a systolic blood pressure fall of at least 20 millimeters of mercury on standing. Next, vasovagal syncope. The distinguishing marker here, during a tilt table test, is a sudden cardio-inhibitory or vasodipressor response, a concurrent drop in both blood pressure and heart rate right before they faint. Finally, spontaneous intracranial hypotension is a huge red flag. It features an orthostatic headache that has a remarkably rapid onset upon standing and rapid relief when they lie flat. Bringing it all together now with Section 6, Key Takeaways, the complete clinical picture. To summarize our core clinical insights from this explainer, keep these 4 vital points in mind. Number 1, POTS presents as a triad of orthostatic lightheadedness, palpitations, and brain fog. 2, these symptoms are consistently worse when upright and get aggravated by heat, large meals, and deconditioning. 3, POTS rarely walks alone. Severe fatigue, gut symptoms, hypermobility, vestibular migraine, and mast cell overlap are incredibly common. And finally, keep your eyes peeled for those red flags. Frank syncope and a true blood pressure fall upon standing should point your diagnostic compass somewhere else.
So now that we've mapped out the clinical presentation, how do we actually confirm it in the clinic? In the next part of the series, we're going to turn this picture into a concrete diagnosis. We'll explicitly detail the active stand and tilt table tests, map out the exact heart rate criteria across different age groups, and walk through the necessary autonomic workup. You definitely won't want to miss it.
Before you go, I want you to consider this. How many of those labeled anxious, dizzy patients sitting in your waiting room right now are actually harboring an unrecognized systemic autonomic syndrome? Think about it. This has been an Australian Dizziness Clinic's vestibular physician review. Visit australiandizzinessclinics.com for the full literature review and clinical cheat sheet.